Colegas, muy buenos días. Les habla Natalia Houghton. Yo soy especialista
Colleagues, good morning.
en
I'm
monitoreo,
Natalia
evaluación y
Houghton,
análisis de sistemas de salud. Trabajo
specialist
con
in
la
monitoring
Unidad
and
de Atención
analyzing
Primaria de la
health systems.
Salud y
I
Prestación
work in
Integrada de
primary
Servicios.
health care
La
and
verdad que es
comprehensive
un placer
health,
de poder
and it is a
estar
pleasure
moderando la
to
sesión de hoy día.
moderate today's session.
¿Cuál es el objetivo de hoy? Es
The
un poco pasar
goal for
desde la
today,
teoría a la
we want to go
práctica
from
en
theory
términos
to
de cómo
practice
uno
in terms of how
avanza
one
en
would
la
advance
operacionalización e implementación
in
del enfoque integral de atención
implementing
primaria a la
the
salud. Así que estamos
comprehensive
muy
primary healthcare
emocionados de
focus.
contar con un
So we
grupo
are very happy to have
de expertos,
a group of
panelistas que nos van a
experts and
acompañar en el
panelists
día de
that will
hoy
be
con
sharing with us
sus
today.
experiencias
They will be
en
sharing
cómo
their
desarrollar
experiences
lineamientos
on
y
how to
cómo
develop
implementar este
guidelines and how
enfoque
to
integral de atención primaria a la
implement the
salud en la
comprehensive
región de
primary
las Américas.
healthcare
Este webinar
approach in the
es el
Americas.
tercero de
This
la serie de
is the
webinars
third
sobre atención
webinar in the
primaria de salud
series,
con perspectiva
the
territorial,
webinars
y
that
bueno,
are
hace parte
primary
ya
healthcare with
de
a
una
territorial
tradición, vamos
perspective,
a
and
decir,
they're
para
part of
la
a tradition
organización, con series de
for
seminarios que
our
se han desarrollado
organization.
desde antes,
Uh,
como por ejemplo la serie sobre
Webinars
funciones
such as the
esenciales de salud
series of
pública, y
how
también
public
una
health
serie que
functions,
tuvimos
and we
sobre
also had a
opciones de
series
políticas,
on
resiliencias y atención primaria de
policies,
la salud,
resilience,
que se
and primary
organizaron desde
healthcare.
los
These
años
were all
2020,
organized
21,
between
22,
2021,
2023, y ahora
2022,
estamos con esta
2023, and
nueva
now
serie sobre
we
atención
have this
primaria a
new
la salud
series
con este
about
enfoque territorial.
primary healthcare with a
Entonces les
territorial
decía, el
perspective.
tema es
So
pasar desde
I
la
was
teoría a la
saying we want to go
práctica
from
en la
theory to practice
operacionalización e
in
implementación
making
el
operational
enfoque de
or
atención primaria a
implementing
la
the
salud, con lo cual hemos
primary health,
titulado
implementing
este
primary
webinar como
healthcare. So we've
herramientas
called
y
this
prácticas. Antes de
webinar
presentar a los
Tools and
panelistas,
Practices.
nada más voy a mencionar
Before
algunos
introducing
elementos
panelists, I
logísticos
want
sobre
to
cómo utilizar la
mention some
plataforma de Zoom en
logistics
la que
issues.
estamos
I want to
conectados.
talk about some items
Primero
related to
mencionarles que
Zoom.
estamos con
First, I want to
traducción
mention that we do have
simultánea en inglés,
simultaneous
español y
translation to
portugués.
English,
Ustedes pueden
Spanish, and
elegir
Portuguese,
su
and
idioma
you
de
can
preferencia
choose the language that
presionando
you
por favor
prefer,
en forma de
pressing
globo que está en la
the
parte inferior de
globe
la pantalla de
button
Zoom.
or icon that
También
you see in the
contamos
lower
con
part of the Zoom
interpretación
screen.
simultánea
We also
del
have
sistema de signos
simultaneous
internacionales
sign
que ustedes podrán
language,
ver
international
en la
sign language
pantalla durante
interpretation,
toda
and
la
you will be able
actividad.
to see this
No olviden por favor que
on
pueden
the
mandar
screen
sus
throughout the activity.
comentarios
And please
y
remember that you can
preguntas
send
en
your
la
comments
sección de
and
Q&A
questions
de Zoom,
to the Q&A
para que
session
al
in
final de
Zoom so that
la
at the end of
actividad
the
podamos estar
activity we can
respondiendo, esperamos, la mayoría de ellos después de
we
tener
hope to be
esta
able to answer
presentación.
most of those questions.
Así que bueno, tengo el gran gusto ahora
So I have
de
now the
presentar al
great
doctor
pleasure to
Shams
introduce
Sid.
Dr.
El
Shams
doctor
C.
Shams es el jefe de
Dr. Shams
políticas
is
y
the head of
alianzas en el
policies
programa
and
especial de
alliances
atención
in the
primaria de
special
salud de la
program for
Organización Mundial
primary
de la
healthcare
Salud.
attention from
Ha
the
sido
World
jefe de la
Health
unidad de
Organization.
calidad
He
de la
has been
atención
head
de la
of the
OMS y
quality
a lo largo de su extensa
service
carrera
unit
ha
of
trabajado
WHO and
directamente con
has
más de
worked
30
directly
países.
with more than
La verdad,
30
Shams, es un
countries.
placer poder
Shams,
contar
it is a
contigo
pleasure
y que
to
nos
have you
acompañes a
here,
participar
to
en este
have you
webinar.
join us
Adelante,
in
por
this
favor.
webinar. And please go ahead.
Thank you so much, Natalia. I'm going to share my screen. And if you could kindly confirm whether you can see and hear me okay?
We can hear you okay, and we can see presentation mode. Thank you so much, Shams. And just as a reminder for the translators, if you can speak a bit slower, but you're doing perfect. Thank you so much.
Thank you, Natalia. And it's a real pleasure and privilege to be with you all today. In this next 15 minutes, as Natalia has highlighted, what I will try to do is to share some thinking in relationship to how primary healthcare can become a reality through operationalization. If I may just start by highlighting the high-level political commitment that we have for primary healthcare, I think colleagues in this virtual space will know very well. Our Director General has spoken about primary healthcare and the fact that it is investing in primary healthcare, which is the most inclusive, equitable, cost-effective, and efficient path to universal health coverage. And these were the words from the UN General Assembly high-level meeting on universal health coverage in September. And at that same meeting and on the same day, at a special event hosted by Chile, Dr. Barbosa spoke very eloquently about how implementation is key, the territorial approach to primary healthcare becoming critical, and health systems rooted in primary healthcare as really a critical pathway for us all in our efforts to transform health systems by investing, by innovating, and implementing. The question immediately becomes, first, primary healthcare as an approach. We know this, but just as a point of departure, we are talking about services, we are talking about empowerment, and we are talking about multi-sectorality. So again, always emphasizing primary healthcare approach as opposed to a primary care services alone. So integrated health services with an emphasis on primary care and essential public health functions. Jumping into the operationalization, many colleagues will have seen this WHO UNICEF operational framework, and this is our point of departure in this conversation. As you can see on the left-hand side, we have the PHC approach, the mention of those three core components. And as you move towards the right, you see PHC levers, strategic levers and operational levers. These are 14 interdependent levers that require our focused attention. And this is where the difference lies from primary healthcare as a value proposition, as opposed to primary healthcare as a concrete and robust mechanism towards universal health coverage. Let's turn to each of those aspects in turn. The strategic levers, you can see the political commitment, the governance, the financing, the engagement, and the operational levers. You can see many of the health system components coming through there in terms of health and care workforce, medicines, and issues such as models of care. Now, all of those interdependent levers require attention. I will return to that in a subsequent slide. An important point of emphasis is that this PHC operational framework comes with a measurement framework. And again, looking back at the history of primary healthcare, this is something that has warranted attention and perhaps has not received the same level of attention in previous attempts to operationalize primary healthcare going back now for decades. But this measurement framework allows us to monitor health systems through a primary healthcare lens. Let me now return back to those levers and go a little bit deeper. So as I mentioned, there are 4 primary healthcare strategic levers and 10 operational levers. The strategic levers focusing in on political commitment, governance, finance, and engagement, and the operational levers focusing in on various aspects of operationalization of primary healthcare approach. And as you can see, this spans models of care, primary healthcare workforce, physical infrastructure issues, importantly, engagement of private sector, medicines, purchasing and payment systems, digital technologies, a subject dear to my heart, systems to ensure quality of care, PHC-oriented research, and monitoring and evaluation. I'm going to pick just one from each of those to explain how that can be taken forward. So as you saw, one of the strategic levers is political commitment and leadership. It's the sort of leadership that heads of state across the world are really putting forward. The action that's required for this is the sustained and continuous political commitment from not just ministers of health, but heads of state and other political leaders, civil society, influential community, religious, and business figures. And importantly, leaders must ensure that PHC is treated as a priority by formalizing commitments. And the operational framework outlines a number of the key actions that can be taken. Let's take the example, one of the operational levers, systems to improve quality of care. Inherent to the PHC approach are systems at the local, subnational, and national levels. And the sorts of approaches that should be emphasized, 3 key points. developing a multimodal suite of interventions tailored to the local context, taking action at multiple levels of the system, so facility level, subnational level, and national level, and focusing in on building a culture that supports the delivery of quality of care. Importantly, when we talk about quality of care interventions, we can think about 4 categories: system environment issues, reducing harm issues, improvement in clinical care issues, and patient, family, and community engagement issues. All of these interventions are outlined in a WHO, World Bank, OECD report. Now, the important part of this description is that each of the levers has associated actions and tools and resources that can be used. So, for example, this lever has a set of tools that can help countries plan for quality of care within the context of primary health care. And this is equally true for all of the different levers. So you can see there's an opportunity to really build. And coming back to the PHC monitoring framework, you can see, and we won't have time to go into the detail here, but the monitoring framework for those 2 examples is clearly there for monitoring the structural issues around governance. As you saw, the example that I was using was political commitment and leadership, and similarly can be used for that example on quality of care. This is equally true for all of the levers that were mentioned. Turning now to the primary healthcare approach and the primer, this was recently released, and it's important for us all to be aware of the primer because it is quite a fundamental approach to try to bring all of the information in one place. The key objectives of this PHC primer is cultivating a common understanding of PHC, elaborating on strategies and actions that can support health systems' orientation towards PHC, and emphasizing the potential of PHC to achieve health system objectives and improve health system performance. Importantly, it is designed to identify common enablers and barriers. There is a clear methodology that I don't think we will have time to go through, and importantly, country illustrations, and this is where really the rubber hits the road. Giving you a quick orientation of the primer, because I would urge each of you to take a careful look. It comes as 3 parts. The first part of the primer is understanding primary healthcare, its history, its power to change, and particularly with a focus on models of care. Importantly, part 2, and reminding ourselves of Dr. Barbosa's focus on implementation, evidence on strategies within the operational levers supporting health system orientation towards PHC. And of course, we're all doing this for impact and performance. Part 3 speaks about the PHC potential to achieve health system objectives, improve health system performance, and resilience. Going even deeper and orienting you to the structure of this key resource, Part 1 has a series of chapters that really focus in on various aspects of foundations, history, and context and concepts. Part 2, and you will see that the likely suspects in terms of health systems capacities are placed there, but each of those chapters synthesizes the evidence on implementation, on governance, on workforce, on financing, medicines, technologies, infrastructure, and information systems and digital solutions. And importantly, as a precursor to further work that WHO will hopefully be doing, is what is the impact on performance, the impact on efficiency and quality of care, the impact on equity, access, and financial protection, the impact on resilience and environmental sustainability, and of course, thinking about a way forward. The primer is scattered with country illustrations, and again, that's gold dust for us in when we're trying to achieve what we're trying to achieve in different contexts, and the diversity of approaches in implementing the PHC approach in different contexts. Each of the parts, and as I was saying, the first part is on foundations, history, and concepts, has country illustrations spanning from the Brazilian example to Ethiopia, Lithuania, Slovenia, Bangladesh, and Chile. All of these can be helping us on our journey on primary healthcare. When it comes to part 2 on implementation, illustration snapshots traverse continents. Costa Rica in their decentralized decision-making with a strong national steer, all the way to Netherlands and Afghanistan in financing PHC in a fragile state, to Brazil's formidable effort on ensuring availability and affordability of prioritized medicines through Farmacia Popular, El Salvador, USA. So we've got a body of evidence on implementation that is developing over time. And of course, part 3, the impact on performance, getting some early signals on how that can happen and what that means for countries as large as China to all the way to Thailand, Spain, Mexico, and Canada. As we move forward, and as I wrap up on this introductory intervention, is that we do need to capture further learning, and it will take us time to capture that learning. The Primary Healthcare Country Case Study Compendium has now been launched, and that serves as a global hub for searching and accessing PHC country cases. We really are looking to see how that can be expanded. Currently, this has around 200 case studies previously published, and nearly around 100 that are in the pipeline. It's our responsibility to collect every shred of experience from across the Americas so that it can contribute to that global pool of knowledge. And of course, there is learning from other parts of the world that hopefully can shed some light on the issues and the practical solutions that are required for PHC in the Americas. I did want to end with just mentioning that, of course, there is all of this effort on PHC, but it will not move forward without a strong focus on the core values that PHC is based on. And I know that all of the colleagues in this virtual space are committed to that, but it is our duty to always highlight that for others across the world, whether it's focusing in on the solidarity aspect, the social justice aspect, the people-centeredness, equity, community orientation, and of course, our bold commitment on health for all. I hopefully have kept to time, Natalia. You gave us very clear instructions. Thank you so much for this opportunity to share some thoughts, and I hope that's been helpful in this discussion as we move forward.
Shams, muchísimas gracias. Súper útil, de hecho.
Thank you, Shams. This has been very useful and great presentation. Thank you. So if you saw Shams' presentation, it included these very useful tools. And by the way, in the chat, we are going to share the links for the operational framework for PHC and also primer, that the primer that Shams mentioned in his presentation. These are two tools that have the elements that have to be considered when one designs a primary health care, with clear examples of how different countries from different parts of the world have advanced by implemented the different components of those drivers of primary health care. So now we're going to look with greater depth at national, local, or regional perspectives of how the countries are advancing in this comprehensive healthcare So with this, we will start with our panelist, Dr. Catherine Rouleau, professor in the Department of Family Medicine, Family and Community Medicine, and family doctor in the St. Michael's Hospital in Toronto, director of the collaborative WHO Center in Family Medicine. After Dr. Catherine Rouleau, we will have the participation of our colleague Sergio Minuet, family doctor and professor of the Andalus Public Health School with 20 years of experience in primary health care. Sergio is also a coordinator of the Collaborating Center of WHO for Primary Health Care. Thank you very much to both of you for joining us today. Then I'd also like to introduce Patricia Castillo, Magister in Administration and from Chile. She is part of the Executive Committee of the Movement for Municipalities, Cities, and Healthy Communities in the Americas. This is a regional local government platform led by mayors, and it has the technical support from PAHO. And finally, we will have the participation of our head of the unit of primary healthcare and comprehensive services, Ernesto Vásculo. Ernesto is an economist and has more than 30 years of experience nationally and internationally working on health policies and services. So I'd like to thank all of the panelists for joining us today. And now I'm going to switch to English so that we can talk to Catherine Rouleau.
Thank you so much for being here. As you saw, Shams in the presentation of the operational framework on PHC, he was mentioning, the different examples. Canada is one of the examples mentioned, included in the operational framework, as well as the PHC primer, and is usually seen as an example, gold standard of the implementation of comprehensive primary health care in the region of the Americas. However, we know that there are also challenges in the implementation of PHC, particularly in recent years in the country, and we wanted to hear from you about that. So the question that we have prepared is, what are the most pressing challenges in Canada, and what can Canada learn from other practices in the region? Thank you so much, Catherine.
Muchas gracias. Es muy lindo de estar aquí. That is the extent of my Spanish for today, but thank you for the invitation. This is an interesting and important question that you ask, Natalia. So as you hinted, Canada is doing very well, but is definitely confronted with some serious problems in the PHC space. I would say that one of the biggest challenges we find is that fewer medical graduates choose to take on comprehensive family medicine. And it's not that they don't, so there's a lower number that pick family medicine, but the really important part here is that the comprehensive family medicine, the committing to a practice, is something that has traditionally been part of our system. 50% of our graduates typically go into family medicine. But the demands of the practice and the way services are organized, the models of care that we use, have not kept pace with the needs of the patient. And that includes team-based models of care. So only a fraction of our patients of the Canadian population can actually access primary care through multidisciplinary teams. When they do, they get great care. But for the physicians who practice in solo practice, without the support of a team, it becomes increasingly difficult to provide the care that's needed by the people. The financial models, et cetera, are also not well aligned to that. So this is one of the big challenges that we find. And it really underscores for me one of the lessons we all need to learn, and I know it is pervasive around the world, that the health workforce in primary care and in PHC as an approach, in public health, across the health system, is really where the rubber hits the road. It'll be very difficult for us to make advances on the health and well-being of populations if we don't have the right human beings to take care and to advance PHC-oriented health systems. I know this sounds really focused on services, but in fact, I do mean this to be even broader. So that's the first part. The other big challenge we have is that we do not de facto have what our Brazilian colleagues, for instance, have, which is a population-based approach. In Canada, people can pick where they're going to get their care if they can find it. 6 million Canadians do not have access to a family doctor now because the family physicians can decide that their practices are full. And that also dissociates the public health approach and the population-based approach from the individual approach. That is a big problem in our case. We, to go back to your question, Natalia, are learning and have learned from Brazil. We've learned a lot from Chile, particularly in my institution at the University of Toronto, where we've been very privileged to collaborate, in particular with teams from these two countries. I think the other issue that is not unique to Canada is the harmonization and the orientation, the synergization of the public and the private sector in the context of health and health services. And this spans, I include under this big rubric attention to the commercial determinants of health, to the population-based approach to preventive and promotive issues, which are sometimes, in French we say déroutés, that are thrown off course by private and commercial interests, but also the important role of the private sector and the contributory elements of private providers in the private sector in general. We know they need to work together. Shams showed that, in fact, engagement of the private sector is one of the levers. How to do this in a way that actually keeps us focused on those values and the principles of PHC that Shams alluded to is a challenge everywhere, especially as budgets are under strain. And it's something that we need to pay attention to. And I'll finish. I could go on, but I'll finish with this notion of learning, because you've mentioned learning. You know, that your question was, what have we learned? In Canada, we have 10 provinces, which means that we have 10 health systems. And what we could do better, and what the Americas actually in many ways are doing better, and what this forum is showing us and encouraging us to do better, is in fact to learn from one another. It means that we need to give ourselves the tools to measure and accumulate the evidence, but it also means that we need to find deliberate platforms, processes, and ways to learn from one another. And I have to say, I've mentioned that we've learned from many colleagues in the Americas and around the world, in my university and beyond. I think this is definitely the invitation of the next chapter of our collective efforts on PHC, to find ways to learn from one another. Maybe I'll stop there.
Catherine, thank you so much. You have highlighted, different important topics. The one that is really resonating with me, I think, is this aspect of different territories or different realities within a single country, and how we can learn, I think, from the different territories and how they are advancing in the implementation of PHC. I think it's very important when we're thinking about learning from other countries, but also learning within the country. That's, I think, how I would like to highlight it, because it's an important topic. In addition, of course, to the other aspects that you were mentioning in terms of having a multidisciplinary team, primary healthcare team, and empanelment as a strategy to not only ensuring access, but also the implementation of, or the integration of public health with health service delivery, which is a key component of the primary healthcare approach, because we need to also think about population-based strategies. So very, very important topics and points you are raising. You were also talking about the collaboration with other countries. As you know, in our region, Colombia, Chile, in addition to many other countries, are also moving forward with implementation of health sector reforms as we are speaking, making different efforts. And health financing is one of those key issues that is, part of a strategic lever within the operational framework, and one aspect that is being considered as part of these health sector reform efforts in these countries. So with that, I guess the next question is, what is needed to integrate health system reforms with financing reforms in these countries? And how do you think policymakers in the region could address the issue? Not easy questions, but
it is not an easy question. And I will say I bring both the strength and the weakness that I am not an economist. I see things as a family physician, as a practical doer. So I will go back to some of the things I've said, but expand on that. So I think for me, the first thing is that it never starts with the budget. It never starts with the financing. It starts with what we want to achieve. And that means prioritizing. It means that when we look at health, not just the health system, when we look at the health and well-being of our societies, of our communities, we need to be very clear about what it is we're trying to achieve. Some of the solutions will involve health services and social services. Many of the solutions will not. And so we need to think about health system financing in the broader context of the kinds of societies and health and well-being we want to expect. It means addressing the determinants of health, not just the commercial ones, but in my country, it means we should have a housing policy. We should, it means that minimum wage needs to be important. It means that the role of women in society and their access to salary parity is important. It means daycare. It means healthy environments. It means attention to climate change and so on. And so that takes a lot of both courage and innovation, because it is not the way budgets are typically constructed. If we go smaller in healthcare, you've mentioned this before, and I will repeat it. I think maybe the focus on the population is the way to go. It doesn't happen in my country, but it makes sense to some extent to think of health expenditures for communities and populations, pockets of people, however we define them, often with a geographical element, so that we can actually put all of their needs in there and then decide, how do we prioritize primary care? And so again, public health and primary care in a PHC orientation are prioritized. How do we make sure that the resources are there, are invested properly? I think it goes back again to Shams. And are we thinking about equity? Are we thinking about solidarity? What does that mean in terms of financing and budgets? How do we tie that to the outcome that we want? How do we prioritize the most marginalized? How do we identify need? How do we quantify, identify, maintain it, monitor it? And how do we then give ourselves the financial means to actually go to that? And lastly, I will say, because I've talked about the multi-sectorality, but I haven't talked about the communities. And we know, in fact, in the Americas, and I would say in in South and Central America, the notion of community engagement is one of the great gifts to the world. Not that others don't do it at all, but it is such a central contribution to this spirit of PHC that we need to make sure that the finances and the funding also enables and does not hinder the engagement of communities. How do we bring them together? How do we give them voice? How do we make sure that this is inclusive? How do we make the participation of communities transformative in the context of health systems? And I will just end by saying, when we talk about financing, it always sounds, I use word funding and financing and allocation and systems. I think it's also very important for us to remember, because this is a session on implementation, that all of these things are a bit screens to mean humans. There are actually individuals whose job it is to make those decisions. And so this is really also an invitation to walk up that chain and figure out who is making that decision. Who's the 1, the 5, the 10, the 20 individuals who have the power to make these financial decisions, and then all the way down the chain to actually give us the outcomes we want and need for our communities. I'll stop there.
Thank you so much. And if I may say, we have 589 attendance today, 590, I'm counting at the moment, on the Zoom and on the Zoom chat. I think your intervention have motivated a lot of exchange. So I invite you to also look at that, because I think what you're highlighting here is, the need for this multidisciplinary discussion, looking at health financing as just an issue of, economists or the people who, have this expertise, but also, putting people at the center. So we appreciate for those comments, because I think it resonates with what, we as an organization are also promoting. So thank you so much for that. And again, I invite you to look at the chat, because lots of comments there. So thank you so much also to our attendance for that. And thank you, Catherine, for your very important topics and comments and contributions.
Muchas gracias.
Bien, colegas, entonces paso de nuevo al español y ahora tengo el placer de darle la palabra a
I'm going back to
Sergio,
Spanish. Now I'm going to give the floor to Sergio, that's going to talk about the tools to implement EPS in the Andalusa school. It's called APS for people, primary health care for people. Sergio, maybe you can tell us about what this initiative is about and how it can support member states and
Bueno, buenos días en América, buenas tardes.
good morning in America and good afternoon here in Europe. First of all, I want to thank WHO as well as PAHO for the opportunity of being here. It's a real privilege to be here at our collaborative center in the Andalusian Public Health School. We have been collaborating for more than 10 years in the strategies that PAHO, that WHO establishes as prioritary. First, we supported the framework on integrated services centered on people from 2016, and since 2021, we are supporting the second great strategic challenge of the organization, which is developing the Astana declaration and the different documents that exist from there. So one of the main media that we have used to try to support those frameworks or strategies is through our webpage, a webpage that initially was called Integrated Care for People, and that tried to talk about that framework and how we can share interesting experiences around people-centered care. And now we have somehow moved. Of course, we have maintained the former platform, but now we have PHC, Primary Health Care for People, or APS in Spanish. In that sense, the webpage summarizes our activity, and it's determined by four great working areas. First, we have events such as this or international conferences that can talk about innovations in primary healthcare. Then we have a resource update. Before we had a weekly update on peer-reviewed magazines or strategic documents from institutions, but also gray literature provided by institutions in the 5 continents that could be interesting in that framework. And so we're doing exactly the same thing in the new platform with a PHC platform. And the third element is allowing a place where practice communities from any place can share experiences in terms of PHC and development. And the last activity is the identification of good practices. In that sense, among our goals with WHO, we have focusing on the operational framework and the performance indicators. And in that sense, our 3 main lines are one, giving small pills of information, videos of the Astana Declaration. Surprisingly, many projects that we have at the school, some people that work in primary healthcare still don't know this well. And of course, we talk about the operational framework and performance indicators. And we also identify good practices, especially in the Americas region, and we support the countries that consider this as interesting through their operational framework indicators analysis. Thank you very much. And thank you for talking about the different tools. The title of this webinar, Tools for the Implementation and Operationalization of PHC, highlights different tools that are available to you and that you can find on the webpage. Right now we are sharing the link on the chat as well. And Sergio, you're an expert in this. You're an expert in organization of care and integrative models. And so I want to take advantage of your presence to ask you where are the main challenges to transform care models in a region? I believe that the main challenges are not only in the region, I think that they're in the world. I think that one of the most interesting features that happening right now is that on one hand, there's a unanimous agreement, and that has not always been the case between any kind of international organization like WHO, PAHO, World Bank, OECD, IDB, so that the systems strengthen PHC as the only way of strengthening the health system and helping and ensuring universal coverage. But I also think that the challenges are common in the world. And to me, the main challenge is that the most important tool that we have is not technological. If we understand people as non-technological beings, there are specialties that have developments in the future through artificial intelligence without human beings. However, a PHC is based on humans. And so I believe that in this sense, the main problem is to attract humans. And this has to do with the fact that it's not fashionable, say it somehow, to provide care that's based on old values. What are old values? Listening, touching, waiting, keeping continuity throughout time. If there's one intervention in health systems that's really effective, that reduces mortality up to 30%, as Sandvik showed in the article, it is maintaining the same doctor for more than 15 years. And the problem is that we have a society that is based on liquidity, immediateness, etc. And so the main problem of health systems around the globe is how to attract talent and retain them. And this is a problem that does not only affect countries in the region because it has remote areas. It's also happening in Europe, in the United States, in Canada. And Catherine might correct me, but there are regions where 20-30% of the population doesn't have a family doctor. And in that sense, providing health care without the professionals that can provide it is an attack on equity. I believe that all the world citizens should have the same services in PHC. So for me, that's a big challenge. And the second one is a disproportion between goals and means. Sometimes we think that this is a problem that only affects PHC or the first level of care. And as we don't change this, it creates a great pressure on the first level of care that is incapable of responding to challenges because it has to turn to the community's problems, the family's problems. And so the strategy, it has to be comprehensive in the system, or if not, we will exhaust our professionals and they will leave the first level of care. So it's a huge challenge, and at the same time, it's a very, very nice challenge. Yes, thank you very much, Sergio, for highlighting that, highlighting the critical aspect implementing PHC and the retention of human resources for health. And there's this vision on the different levels of care that you were talking about. So it's a huge challenge, but everyone is have to work on that. And thank you also for your invitation on working on that, because it's a very exciting challenge to see how we tackle this in a more integrated manner. And thank you very much for those thoughts, Sergio.
Bien, ahora nos vamos entonces, ¿vieron cómo vamos transicionando?
And now we are transitioning from the national experience in Canada, and then we're having a more regional vision, and now we're going to the local perspective. That's very important, and it is one of the elements that we're trying to foster at our organization, trying to look at PHC in specific territories. And for this, we have Patricia. She is, thank you very much to Patricia for being with us at this webinar. And we also want to thank our colleagues from the health promotion unit and the office, and Patricia, they have introduced us to Patricia so that she can do a presentation today. Patricia, the documents that we have and the documents that the panelists have commented on are centered on people's autonomy and on community voices to guide the PHC approach. And so understanding that from the experience of the Renca municipality, what is the place of municipalities and local governments to implement the PHC approach?
Bueno, primero, buenos días a todos.
Good morning.
Contarles que,
I want to
bueno, no sé
tell
si
you,
todos los que están
I don't know if
en este webinar,
everyone that's
Chile, la atención primaria está radicada en los
here knows that in
municipios, o sea,
Chile,
gobiernos locales.
primary
Si
healthcare
bien es
is
cierto que
based on
desde el
municipalities.
contexto técnico, seguimos
In the
todas las
technical context, we follow
normativas
the
desde el nivel central,
orientations and the
pero está
regulations
radicada
from
en
the
los
central level, but
Y eso,
PHC is
desde,
based in
mirado
the
desde
municipalities.
alguna manera,
And so
una mejor posición para ir a escuchar las voces de nuestros vecinos, de la
I'm
gente
sorry,
que
but
vive
the
en
audio
territorio
got cut
y
off.
que permite en el
There are
fondo que
people that live in this
nosotros
territory, and
moldeemos la
we
entrega
have
de
to
la
mold
atención primaria
the
respecto de
delivery
lo que
of
nuestros
primary
vecinos
care regarding what
quieren
our
o cuáles son sus necesidades.
users want
Porque
or what are their
mirado
needs.
de la esfera
Because
más
if we look at
macro,
this from the more
nacional,
macro sphere,
es
the
complejo ir
national
al
level,
territorio
it is
y
complex to go
saber
to the
exactamente
territories and
cuáles
to
son las
know
deficiencias o cómo nos miran.
what are the deficiencies and
Nosotros
how
tenemos
our
en
neighbors look at
Renca
us.
una historia
At
larga
Renca, we have a
que
long
parte,
story.
yo diría, post pandemia, en que nuestros diálogos
That started
ciudadanos con los
after the
vecinos se hicieron
pandemic,
vinculantes.
and
¿Qué quiere decir
our
esto? Nosotros le íbamos a
dialogues with the
preguntar
neighbors
qué es
started
lo que
becoming
ellos
binding.
pensaban respecto
We asked them
de
what they
salud, qué
thought
querían,
regarding health, what they wanted,
lo que ellos
but
querían,
what they wanted,
modelamos proyectos y los
we
hacíamos
modeled
votar y los
projects
priorizábamos los
and
proyectos. O sea,
we
no iban a decirnos
made them
falta
vote, and then we
A,
prioritized the
falta B, falta
projects.
C,
So we
sino que
didn't
además
say
nosotros
we lack A,
actuábamos
B, or
sobre eso.
C. We
Y eso
acted
es
upon
porque
that, and this
el
is
gobierno
because
local
the local
puede
government
hacerlo desde
can
alguna
do
perspectiva,
that
¿ya?
from its
También
perspective.
ha ocurrido que ya llevamos
What
nosotros
also happened is
3
that
para
we
4 años
have
en que
been,
además de los objetivos
it's been 3 or 4
nacionales,
years
nosotros
in
tenemos
which
objetivos
beyond national
estratégicos
objectives,
propios municipales que
we
están
have
orientados precisamente
strategic
a
objectives that are
estos diálogos
oriented
ciudadanos, ¿ya?
to
Y que
these
además eso tiene recursos,
citizen
porque
dialogues, and
uno
this
como
has
tomador de
resources.
decisión
Because as
local
as local decision
puede
makers,
solo saber qué
we
quieren los
cannot
vecinos que viven en sus
only
territorios, sino que además tiene que tener
be
recursos para actuar sobre ello,
what
¿ya?
neighbors want,
Y eso es lo que ha
but
estado
we
sucediendo
also
hoy
need to have
día,
resources
porque
to
nosotros,
act
por
upon
ejemplo, por
that.
darles algunos ejemplos, la gente
And
en
I
2021
believe
dijo
that
que ellos querían
people, for example,
mejorar la
people in
experiencia
2021
usuaria de
told
ir
us
a un
that we wanted
establecimiento de
to
salud, ¿ya? Que los
improve the
establecimientos estuvieran en
experience
mejores condiciones,
when they went to health
que la
establishments.
forma
They
de
want to
conseguir
health
una hora
institutions to
fuera
be
más
in a
fácil, que
best condition and better conditions. They wanted to have easier appointments. And so we started looking at this through different projects to improve infrastructure, manage the offer with line 800 web pages, telehealth. Before we had teletriage from PAHO. And we have been able to incorporate different tools that are available today. We are not inventing anything. We have integrated things that already existed, but this is thanks to the fact that we're close to people. We have decision-making power, and we also have resources that allow to tell the mayor and the municipal council that these are the objectives that we have for this year. We tell them this is what we're going to do for these objectives, and this improves the care for the neighbors. And so we have improved mental health care. We deliver medicine to the homes of people that are more than 75. And I also heard this from the other panelists. We are in a reform process, and Renca is one of the pioneer communities for the universal pension. What does this mean? That the people that live in the Renca territory can get services in the primary care level. And 17% of the people are not in FONASA, which is the public insurance. And since last year, we can do those, provide that care universally. And that's the right approach because it allows to prevent and promote in the whole of the population. And so our indicators might not be improving right now, but probably in 10 years, the Renca population will be healthier because we are intervening on all people and not only on the people that are covered by the state's health insurance. And so it's relevant and it's important to have autonomy at the local level. And we have an important and relevant role to play. And this is something that the Ministry of Health is seeing because they are listening to those that have created these practices. There are a lot of good practices around the country, and the ministry is looking and listening at those good practices, and they are including the reform and the universal PHC. Thank you very much, Patricia. And I can see also that the chat was very active during your participation. What are you mentioning about autonomy and social participation, about them being binding and tied to budget is very important to execute the elements that are identified as important. Thank you very much for your intervention. And you were also mentioning the reform process that's happening in Chile. This is something that we have been commenting on during the webinar. And in that case, there are different orientations that are being created for the Chilean health system in the primary healthcare level. And I wanted to ask you, what are the actions that are being prioritized for Renca in this case? Among the actions that we are prioritizing, we have improving the relationship between the community and the institutions. This is why we have, for example, this year we're going to have citizen dialogues in the context of climate change. Last year it was in the context of universal PHC and improvements. And so we have to improve the relationship between the community and all the institutions and health officials. And the second point is having multidisciplinary teams. Today, the reform and different ministry interventions, we look at patients in their multimorbidities. It means that patient is tended to in a much longer period of time by a multidisciplinary team that looks at all the pathologies. They see arthrosis, hypothyroidism. So we're looking at the patient from the comprehensive perspective. And this is another thing that we are including. And the other point is efficiency. Efficiency in resources. And for that, I also heard about this in the other presentations. It's very relevant to have information. We cannot make decisions if we don't have data that's valuable. And so we, for third year, we have a data unit, and this is something that's not frequent in health because in general, we measure our production through a monthly statistics, but there's a lot of data that's not there and that is very useful for decision making and that defines how you measure the efficiency of your health resources. And so in Renka, we created a data unit that allows us to create to gather different data that we use to make the different decisions. And this allows us to know about the winter campaign peak, how we have to move the hours, where do we put more efforts in, but from database decision making. And we have also highlighted the role of what's preventive. We are exiting institutions and we're going to the territory. We have fairs, we have care during community meetings, so we are taking care to the users. 3 or 4 years ago, we built community health centers because we were lacking infrastructure, and these community health centers were closer to people that go to these small places. And so these have been our footprints or our prioritizations in our health plan in Renka. Thank you very much, Patricia. Wow. Yeah, your approach is very comprehensive. Thank you for sharing that experience. And something that touches my heart is accessibility and what you were mentioning at the beginning, improving the relationship between the community and the service, because this is great. It improves access, it improves trust and the knowledge that health suppliers have and knowledge that the population has. So thank you very much, Patricia, for sharing your experience. And well, I'm mentioning this for everyone. We have 680 participants connected through the Zoom, and the chat is very active. So I invite you and the other panelists to continue exchanging in the chat.
Bien, paso ahora.
Good.
Hablar
And now I'm going to talk about another element with the participation of Ernesto, our unit team. We're going to talk about integration. Our panelists have been mentioning provision of services and the public health areas to have an approach from the population level, but also take into consideration social and commercial determinants, as Catherine was saying. And the operational framework that Shams was talking about mentioned the integration of services, an approach on the first level of care and also essential services. So Ernesto, this is the introduction. The question for you is, how is the region making progress on strengthening PHC functions after the renovation in 2020?
Y la
Thank you
verdad
very
que
much for that
necesito
question,
expresar
and I do
placer
need to express
de
the
participar en esta
pleasure
conversación con los colegas.
to
Me
participate
va
in
a
this
resultar
conversation with our
difícil,
colleagues,
creo que lo mismo que le pasó a
and
Patricia,
it's going to be
no
difficult, and I think this
reaccionar teniendo en
happened
cuenta
to
las
Patricia
presentaciones previas, digamos, ¿no?
to not
Me
react to the
parece
previous
que hay
presentations.
un
I
hilo
think that there's a
complementario.
thread
Yo creo que cuando hablamos de
there.
funciones esenciales en
I
salud
think that
pública,
when we talk
para
about essential
nosotros
functions in
en
public
nuestra
health,
región, en la
for us
región de
in
las
our
Américas,
region, the region of
nos
the Americas,
retrotrae a
this
una agenda que
this
tiene más de 2
brings
décadas,
us
que
a
como bien
2-decade-old
comentabas
agenda.
vos,
And as
Natalia,
you were saying,
ese
Natalia,
marco
that
renovado de las funciones esenciales de salud
renewed
pública
framework of
llega en
essential
un
functions in public
momento
health
clave, ¿no?
arrives at a
Tiene
key
una
moment.
referencia clara
It has a
dentro de la estrategia
clear
de salud
reference
universal
within
aprobada ya
the
en el año
universal or One Health
2014,
strategy that was approved back in
pero
2014.
esa
But
propuesta que
that
busca
proposal
en
that
realidad fortalecer la
is meant
rectoría,
to
la
strengthen
gobernanza de los
the
sistemas de salud,
governance
para
of
mí se
health
articula con uno
systems,
de los puntos
for
que
me
tiene que ver
connects to
con
one of
lo
the
que
points,
planteaba
and that
Catherine,
is
que me parece
connected to what
fascinante,
Catherine was
es que
saying,
esta
and
agenda
that
de
is that
atención
this
primaria
primary
necesita
care
articular,
healthcare
integrar
agenda needs
las
to
agendas de reforma del
include
financiamiento con las
financing
reformas de atención
reform
primaria,
agendas with
reconociendo
primary care
que la
reforms.
lógica de
We
esta
have to
transformación
recognize
tiene que
the
partir
logic of
de
the
las
transformation
necesidades de la
has
salud de la
to begin
población,
with the
tiene
needs
que
of a
surgir
population.
de
Has to
avanzar
come.
sobre las limitaciones en la capacidad
It has
de
to advance
respuesta que
on
tiene
the
no
existing
solo los servicios de
limitations
salud,
for
sino
response
la
capacity, not
estructura del
just
Estado con un
for
abordaje
health systems, but
intersectorial.
also the whole
Y
state
eso
structure.
es algo que
And
está en el
that is
corazón de esta
something
nueva
that is
propuesta de
at the
funciones
core of
esenciales en salud
this
pública.
new
Y es por
core
eso
is
que
at the
yo
core of
creo
this
que
new proposal
también no es
for primary
solo el
functions
tema
in
de la estrategia
public
de
health.
salud
And it's
universal,
not just
sino que
a
está
One Health
fuertemente
approach,
ligado
it's also
a
strongly
este marco
connected
de atención primaria de
to
la salud. Para mí
primary
esto es
health
clave
care
porque además
services, because I think this is
desde
key.
que lanzamos
Since
el
we
nuevo marco
launched the
conceptual
new
de funciones esenciales en
theoretical
salud pública y
framework
también hemos
of essential
desarrollado
functions in
una
public health
agenda de
and
medición y de
the
desarrollo de estas funciones
measurement and
esenciales
development
en salud
agenda
pública, nuestra
for
región
essential
ha
functions in
avanzado
public health,
enormemente,
our
no
region has
solamente
advanced, not
evaluando
just
el nivel de alcance, de
assessing
avance, de
the
brechas en las
scope, the
funciones
advances,
esenciales
and
en
the
salud pública.
gaps of these essential
14
functions in
países,
public health.
14 estados
14
miembros
countries,
de nuestra
14
región en los
member
últimos
states in our
3
region
años
in the
han
last 3
hecho
years have
un ejercicio con un nivel
carried
de
out
participación muy
an
grande, de alguna
exercise
forma
with a lot of
interpelando,
participation,
reconociendo cuáles eran los desafíos más importantes
recognizing the
que
most
tenían su
significant
sistema.
challenges that
Pero
their
quiero
systems had
destacar que
or faced.
10 de
But I
esos
want to
14
mention that
países
10 out
incluso
of the
dieron
14
un paso
countries
decisivo elaborando
took a
planes
decisive step
estratégicos, ¿no?
by
Para abordar
making
ese tipo de
strategic
desafíos.
plans to be
Esto
able to address the
me
challenges
parece
they
que
found.
contribuye y
And
está
I
muy
think this
alineado con esta
is
discusión.
aligned with
Hace
this
solamente
discussion.
10 días el Comité
Only 10
Ejecutivo
days ago, the
de la
Executive Committee
Organización Panamericana de la
of
Salud
the Pan American Health
aprobó
Organization
ya
approved
una resolución de funciones esenciales en salud
a
pública que
resolution
lo que
for essential
busca
functions in public health,
justamente
and
lo que los estados nos
it's
están
looking
requiriendo
for
es
what the states are
fortalecer
asking. They're
este camino
trying
y
to
ya no
strengthen
solo con
this
una mirada,
uh,
vamos a decir, macro
path, and
participativa
not just
de
with a
gobernanza a
macro
nivel
participative
nacional,
and governance
incorporando
look,
como con un rol de liderazgos a las autoridades
including
de
the
salud, sino
leaderships of
también
health
en una
authorities, but
implementación
also
en los
in an
territorios y
implementation
alineados
in
con esta
territories
lógica de
aligned with
APS.
this
Hay 3 elementos, hay
PHC
3
logic.
líneas
There's 3 elements
de esta estrategia que me gustaría resaltar. La
in this
primera,
strategy
que es
that I want to
obvia y que
mention. The
tiene esa
first
mirada
one that I think
estructural,
is
que
obvious
tiene
and
que ver
has a
con
structural
fortalecer el
element is
liderazgo,
related
la
to strengthening
rectoría de las autoridades de
leadership
salud y la
and governance
gobernanza del
of health
sistema.
authorities
El segundo
and the
punto,
system's
que yo
governance. The second
no puedo
point
dejar de
that I
articularlo
have
con lo
to
que
also
planteaba
include and connect to what
Patricia en algún
Patricia was
momento, que tiene que
saying,
ver con
and this is
fortalecer esa
related to
capacidad de
strengthening
evaluación de las funciones,
the
pero en los distintos
evaluation of
niveles,
functions
¿no?, del
capacity
sistema.
at the different
Es un
levels of the
ejemplo
system.
sumamente interesante
This is a
lo que
very
en Renca se planteaba,
interesting example
la
proposed in
práctica que están
Renka.
haciendo, incorporando el
The
desarrollo de esa
practice
capacidad
of
de analizar problemas, de
developing
articular
capacities,
recursos, de
of
fortalecer
analyzing
capacidades,
problems and
articulando
strengthening, and
algo me parece de nuevo importante resaltar
Connecting to something I think is also important, and that is the connection between the national agenda and the development capacity in a community or locality. And I think that this is key when we try to interpret this strategy in a complete way, trying to strengthen capabilities at all levels. And lastly, strengthening personnel skills so that we can apply essential functions in public health. This is one of the last lines of the strategy, and this is something that I also have to connect to one of the comments from Sergio. I think that this whole process cannot be done without placing as an engine, a driver of these processes, human resources. We have to strengthen human resource skills. I mean, the abilities to work on the concepts of primary healthcare, their skills in working in a territory, their technical skills, but also political skills to be able to work on a complex and ambitious strategy that is necessary at this time. Thank you very much, Ernesto, and for the summary, I think, of the different interventions and this connection with the essential functions of public health and this systemic view of the different elements. Thank you very much for this. And talking about integration, we are talking about integration through the essential functions in public health, but the other element of integration is integration of PHC in services and priority health conditions programs where the important agendas of PAHO are related to eliminating transmissible diseases and the strategy for non-transmissible diseases. Considering these two strategies, these two initiatives, and this concept of integration, the question is, which practical recommendations would you give to apply a PHC focus on these two strategies? Okay, thank you very much for the question. The key word here is integration. And it's a dimension or a concept that reaches every level. And I don't mean just national, it affects local, meaning community level, and even
a la salud global, digamos, ¿no?
global
y a
health.
los organismos que
And
de alguna forma
the entities that in some way contribute or
con agendas
contribute
de desarrollo,
with
con cooperación
development
técnica, con recursos. Y este es el
agendas,
caso de la Organización Panamericana
technical
de la Salud,
cooperation,
como
or
bien
even
mencionaba muy
resources,
bien
as is the
recién.
case of
Es decir,
PAHO.
cómo este
How
concepto de
does this
atención primaria
concept of
tiene que
primary
servir como
healthcare,
plataforma para hacer
how is it used
efectiva
as a
estas
platform
dos
to
iniciativas que
make
han sido
these
consideradas
two initiatives that
como
were considered
estratégicas,
as
prioritarias en la
strategic
administración
and
actual de la Organización
prioritary
Panamericana de la Salud?
in
Y
PAHO
esto
currently? How do they
nos
apply?
interpela
And
a
this
nosotros para repensar la forma
leads us to
de la
rethink
cooperación técnica y cómo
technical
se trabaja
cooperation
con
and
con
how
una perspectiva
we
centrada
work
en los
with
países.
a
Y
perspective
acá
that is
no puedo
focused
dejar
on
de
the
nuevo
countries.
de destacar
And
la
again, here
misión
I
de la
would
atención primaria,
mention the mission
pero
of primary
especialmente
healthcare,
la mirada de la atención primaria con
especially
una perspectiva
primary
territorial, que me parece que
healthcare
eso
with the
es un
territorial
elemento que nos
perspective, which I think
organiza
is an
en el
element
trabajo en
that
cada uno de los niveles sobre los cuales
organizes us
podemos
at
estar
each
trabajando.
one of the levels
Esta
that we
mirada de
work in.
atención primaria con una
This
perspectiva
outlook
territorial
of
implica,
primary
por
healthcare
sobre
with a
todo,
territorial
esta
perspective
necesaria articulación
requires connection with a territory, recognizing the problems. And when I say problems, I don't just mean an epidemiological map, I mean the needs to interpret. And the elements that you mentioned before is the critical challenge, not just of the response capacity of the services, but the structure of that society and the ability to respond or to those needs. And accessibility to that response capacity is fundamental. And when I talk about accessibility, I'm not just talking about barriers related to supply or offer, meaning lack of resources or problems with coordinations in health services or reorganizing the distribution of services, human resources, technology, and to provide continuity to the different healthcare services, but also to interpret the challenges related to the social determinants of a population. This in a territory means that we should map the stakeholders that have the ability to intervene on those problems. And when I talk about these stakeholders, those that work in services in the different levels focused on primary healthcare, but with the ability to connect to other agencies or sectors that will have effects on health. And on our side, as Pan American Health Organization and with other partners, work fundamentally on interpreting these challenges and bringing our tools, harmonizing our technical cooperation tools to the services so that we can have an integrated and comprehensive focus. This is what I would mention about your question. Thank you very much, Ernesto. So we are a little bit delayed in the time, but I think the interventions have been fabulous, and we have a lot of questions and comments in the chat. So we have picked one for each one of the panelists. These are the questions from the audience. I'm going to read the questions so that you can prepare the answer. So you will have 2 minutes to answer for Shams. And I'm going to switch to English now.
How can WHO support the implementation of some of the primary recommendations, not only for national, but also for subnational health authorities and local governments? That is the question. For Catherine, one of the issues often seen in primary care is the significant human resource gap, which hampers the effectiveness of interventions and is often not prioritized. What is your opinion on this issue in the implementation of improvements? Para Sergio, el doctor Sergio Minué mencionó la inadecuación de tener poblaciones.
Dr. Sergio Minet talked about the lack of health teams or professionals to guarantee comprehensive attention. Considering the 35 million people that live in the Amazon in 10 countries in the Americas, how can we include more clearly the need to look for alternative models to respond to these realities through primary health care? For Patricia on binding dialogues, this new focus has been modified by changes in office, or has it become a state policy? And what strategies have you had to develop competences of those who participate, local authorities and community leaders? For Ernesto, we consider that the work in essential functions in public health and integrated networks for primary health care and services are interdependent and require a relationship with the formation of human talent. So the question is, considering the challenges discussed, do we have the adequate tools to move forward? If not, what do we need so that we can accelerate the PHC focus? Shams, we go with you.
Yeah, thanks, Natalia. Thanks for the question. So just to clarify, the primer is a source document. It's reasonably comprehensive. And with that comes length. And it's not for light-hearted bedtime reading. It is big. And thank you for the colleague who pointed this out. What we would like to do is extract out some key policy briefs on specific issues that can then be utilized at the national and subnational level. And importantly, we would be very keen to link that with local learning. And that's one of the points that I was emphasizing, and listening to the wisdom of the panel re-emphasizes that. We really need to capture the lessons and the issues and solutions at local most level, so that the documentation that has been produced, and it's important to have that as a foundation, the action is local. And that learning cycle, and that's why I was emphasizing the case study compendium, will allow us to bring everything to life. And that will take time. And as colleagues on the panel have highlighted, this is not a new agenda, it's a decades-long agenda, and it will stay with our children and our grandchildren. But we have a responsibility to shape that learning so that when colleagues are having this discussion in a couple of decades, we've done what we can do at our point on this issue. So rest assured, we would be very keen to work with all colleagues to capture the lessons, and importantly, the issues, the problems, what didn't work. Those are things that we really need to capture through some of the mechanisms that have been described by colleagues on the panel. Natalia.
Shams, thank you so much. And I'll now give the floor to Catherine.
Thank you so much for that question about the health workforce. There's no doubt in my mind that the solution to PHC and to health and well-being in general begins and ends with the health workforce, and not just at the clinical services, but beyond. I think that the question was, there's a shortage everywhere. What do we do? Well, we need, as Sergio so eloquently pointed out, we need to inspire and engage and revive this interest in what I consider to still be the most rewarding area of primary care and generalism. So we need to increase numbers. We also need to increase the diversity of our teams, the types of skills and scopes, and the way we come together. So I often compare the health workforce to a blanket. We need a larger blanket, but we also need a blanket that stretches better, and one that is thick enough to actually be good both in cold and hot weather. So that covers a lot of needs across the communities. We also need that health workforce to be better at reaching and holding hands with community members that may not have formal clinical training, but in fact plays a vital role in reaching into the community and bringing the voice of the community. I think we need to highlight generalism, cultivate generalism. We need to cultivate those human dimensions, again, that Sergio spoke about so clearly. And I think we need to be bold and sustained. There are 724 people, according to my screen right now on this call. I have zero doubt that if they locked us all up or put us on a nice island somewhere, we would bring solutions to many of the problems. And so yes to the health workforce, and yes to us holding hands together and really then implementing some of our ideas and creative thoughts. There are potentially enough of us to do the job. We need to do it better, and we need to do it in systems that allow us to be optimally effective in what we're doing. I'm going to stop there. Thank you.
Catherine, thank you so much, and for that invitation of working together as well. Sergio, adelante.
Sergio, it's your turn.
Sergio,
Estás
con el micrófono apagado.
You're muted.
No, decía
Sorry.
que el problema que plantea la pregunta yo creo que
The
es un problema de
problem
una
in the
enorme
question, I
gravedad y
think
de una
this is a
dimensión
very
universal.
serious problem, and
Los
it has a
servicios
universal
sanitarios tienden
dimension.
a
Health services
concentrarse cada vez más
usually
en las grandes
focus
ciudades, en
in
las
the
grandes
big
urbes,
cities, in the
generalmente
big
en los barrios
urban
más ricos,
areas,
y para el
and in
resto
the
de la
wealthier
población, los
neighborhoods, and
servicios
the
son
rest
de
of the
segundo
population
nivel, de segunda
receives
categoría.
second category, second level
Una de las
services.
cosas que yo creo
One
que
of
es
the
evidente
things
por
that
la
I think is
envergadura y la
evident,
dimensión
given
de los
the
retos que tiene la atención primaria de salud,
size of
es la
the
necesidad de
challenges
tener
in primary
múltiples
healthcare, is the
perfiles.
need to
La
have
idea de que la
multiple
atención
profiles. The
primaria
idea
en
that
el
primary
futuro pueda
healthcare in the
continuar
future
siendo
can continue being something that is provided exclusively by a medical or nursing professional is not viable. And in fact, the region has many examples to teach the rest of the world, and specifically Europe. And I'm going to give you a specific example, and that is the community health workers, the community health workers, and there's scientific evidence that shows the improvement of a population's health when you have this type of professional. Andy Hayes, a London professor in the Lancet, proposed the hiring of 100,000 community health workers for the British national health system. But having said this, currently it is impossible to have high resolution capacity at a primary health care level. Right now, artificial intelligence does not provide us an alternative to substitute them. So resigning to having primary health care because it's a remote or because it's a violent area will not have doctors, I think, is strengthening an inequitable model. So I think, again, what we have to look for is alternatives to bring doctors to any place. And Chile, with the general doctors for zones from Allende, showed that there was possibilities so for any country and any area to have this type of professional to resolve problems that other professionals cannot resolve.
Muchísimas gracias. Le doy la
Thank you
palabra a
very much,
Patricia.
Sergio. Now we go with Patricia.
Gracias, Natalia. Bueno,
Thank
la
you,
pregunta
Natalia.
respecto
Well,
de
the
los
question
diálogos
about
vinculantes,
the
si
binding
se
dialogues,
modifica o no con los cambios de
if it's
gobierno, bueno,
modified with the
decirles
change of
que
office, well, I would say
en el
that
caso nuestro,
in
los
our
gobiernos
case,
locales
local
pueden
governments
durar hasta 12 años. Eso
can
quiere decir
stay for
que
12
un
years.
alcalde se puede
That
reelegir
means that
dos
a
veces,
mayor can be
lo que
re-elected 2 times.
significa que
And
en
this
el
means
fondo,
that in the end,
si te mantienes con
well,
tu mismo alcalde,
if you
en
stay with
Chile, que
that
es lo que nos ha
same
ocurrido a
mayor,
nosotros, de
which
hecho,
is
hasta
not
ahora,
something that has happened to us, by the way.
no hemos tenido el factor cambio de
Well,
gobierno
it
que haga
has
que
happened to us.
tengamos
That
que
means that we haven't had
modificar
a change of office
nuestros
that
diálogos
led us to
ciudadanos, ¿ya?
modify our
Yo sé
dialogue.
que en la
I know
audiencia hay
that
muchos otros
in the
países
audience we
que
have many other countries where
gobiernos locales duran
their
menos
local
tiempo.
governments
Pero yo
last
creo
a
que
lot
aquí
less. But I think that
la llave o el centro
the
donde uno
key
tiene que poner
or
esto es que en la medida que uno
we have to
involucra
focus on the
en
fact
este
that in the
diálogo
measure that you
ciudadano a la
involve
comunidad,
community into the citizen
propia
dialogue,
comunidad la que
the
va a
community
exigir
itself is
que
the
los
one that is
siguientes
going
diálogos
to
ciudadanos siempre sean
demand
vinculantes. Porque
this
cuando una
binding
comunidad se
citizen
acostumbra a
dialogue,
que tú
because
lo
when a
escuchas
community gets
y
used to
después de
being
esto
heard
lo que
and
propones son
after being
distintos
heard
proyectos
uh,
y la
have different
ciudadanía
projects implemented,
los
the
prioriza,
citizens
tú
creating
generas
priorities,
esta
you are
estrategia
creating
o
this
esta
strategy or this
idea de cómo priorizar los
idea
distintos
of
problemas
how
de la
to
comunidad y después lo van a
prioritize
exigir.
community
Aunque
problems, and then they
sea
will
un
demand
tiempo
it,
breve y
even though
corto,
it's
de
a
4
short
años, por
time,
ejemplo, un
4
gobierno
years, for
local.
example, for a
Si tú
local government.
involucras a la comunidad,
If you
probablemente
involve the
ellos
community,
van a
they
preguntar
will,
después en un siguiente gobierno
after,
local,
in
¿y
the
por qué
next
no
office, they
estamos
will
haciendo lo
ask,
mismo
why are
que
we not
hicimos
doing the
antes?
same
¿Ya?
thing we were
En
doing
nuestro caso,
before?
como les digo, ha sido
In our
menos
case,
complejo
we haven't
porque
had that
estamos en el
complication
mismo
because
gobierno local.
we are
Y
still
ahora
in the
respecto de
same
las
office.
capacidades de
Now,
quienes
regarding
participan,
the
nosotros hemos ido
capacity of those
con distintas
participating,
etapas. Con el
we
primer diálogo
had
ciudadano lo
different
hicimos más bien
stages
desde
in
lo
the first
técnico,
dialogues.
que
We
armamos
had
este diálogo y
the
dijimos hagámoslo
technicians, and we
vinculante.
said,
No
let's build this
existían los
dialogue. We
diálogos per se, no
decided
son
to make it
vinculantes y nosotros
by
decidimos en ese
binding.
momento
It didn't
armar
exist back then, so we
diálogos
decided to
vinculantes y lo hicimos
create
desde lo
these
técnico.
binding dialogues,
Pero en
and we
nuestra
did it
segunda
in the
versión, que fue
technical
el año
sphere.
pasado,
But in the second version, last
existen
year,
en cada establecimiento de salud
each
algo que se llaman los
health
CDL, que
facility
son los
has the
consejos de desarrollo
CDLs.
local, que
These
son
are
una especie
the
de
local
consejo
development
consultivo,
councils. These are
que son
sort
los
of
mismos
advisory
pacientes que se
committees,
atienden en los
and they are
establecimientos que
formed
conforman
by
este consejo
patients
consultivo,
that
y los
belong
hicimos
to these
participar a ellos también en la
council,
construcción del diálogo
and
ciudadano.
we
Entonces,
had
en
them
el siguiente
participate in
ya no fuimos
building
los
the
técnicos,
citizen
además se
dialogue.
sumó
So
la
we
comunidad
then
a
didn't have
preparar
just the
cada diálogo.
technicians, but we
Ahí
had
es
the
como haciendo el
community preparing the
levantamiento de
dialogues,
lo que queríamos
and
ir a mirar en cada diálogo.
we were
Entonces, eso
able to
respecto
address
de
what we're
todas
seeing in the
las
dialogue. So
preguntas que
that's
me hicieron.
regarding the questions I was
Excelente,
asked.
Patricia, muchas
Excellent,
gracias.
Patricia. Thank you
Ernesto,
very much.
adelante, por favor.
Ernesto, go ahead.
Bueno, gracias. No
Thank
es
you
una
very much.
pregunta
This is not
fácil de
an
responder
easy
en
question
2
to
minutos,
answer
digamos, ¿no?
in 2
Pero
minutes
voy
at
a hacer
least,
todo el intento.
but I will make my
Si
best attempt.
si disponemos de
If we
herramientas para
have
esta agenda que
tools
incluya
for
desde
this
la atención
agenda
primaria de la salud, hasta funciones esenciales en salud
including
pública. La
primary
respuesta
healthcare
corta es
and
sí.
then essential functions in public
¿Por
health? The
qué?
short answer
Lo
would be
digo ¿por
yes.
qué? Porque eso
Why?
requiere
Because this
tener
requires
herramientas con las cuales
having
no
those
no
tools
solo se han adaptado a las distintas realidades
that are not just
de los
adapted to the
distintos
different
países y
realities
los
of the
distintos
different
niveles
countries
a nivel
at the different
nacional y
levels,
subnacional,
at
en las
national and
distintas subregiones
sub-national levels,
con
and the different
adaptación a países federales,
sub-regions
pero también al
adapting, for
Caribe,
example, to federal countries or Caribbean
a
countries
contextos de procesos de
and
reforma.
reform
Estas
processes.
herramientas como la de
These
funciones
tools,
esenciales en salud
such as
pública,
essential functions in
partieron de
public
una
health,
versión general,
came from
pero
a
después el
general
nivel de
version, but
producción, de
then the level
adaptación, de
of production
enriquecimiento
and
en cada
adaptation
uno de los
and
casos
enrichment
fue
in each one of the
decisiva, ¿no?
cases is
La
decisive.
apropiación de
The
esas herramientas
ownership
por
of
parte de
those
los
tools
sujetos,
by the
actores que llevan adelante la
stakeholders that
agenda,
are
creemos que son
implementing the
más
agenda
fundamentales
is
que
more
simplemente tener
fundamental than
una
simply the
herramienta en sí
fact
misma.
that
Pero
we
también
have
quiero
a tool
destacar
itself. But I would also
herramientas
like
que
to
tienen que ver
mention
con
that
barreras al acceso a los
tools
servicios de salud, de
related to barriers
planificación de
in
primer
access
nivel
to
de
health
atención,
services
de
or planning in
integración con
primary
redes.
healthcare levels
Pero cuando
and
hablamos de
network
herramienta,
integration. When
no
we talk
quiero
about
dejar de
tool,
considerar como parte de ese
I want to
arsenal
consider
todo lo que
part of the
significa los
arsenal
procesos de formación de
everything
recursos
that
humanos,
is related
las
to training
capacitaciones,
human
incluso el diálogo
resources,
social
trainings
que
and
hace
even
posible
social
lo que Patricia
dialogues
planteaba
that
inicialmente
make
como un
what
elemento
Patricia
central en
proposed
donde es
possible,
necesario
the central
garantizar
element of
esto, ¿no? La
guaranteeing
perspectiva, no solo las necesidades, la
the not
perspectiva,
just
la
the needs, but the
participación de
perspectives,
las
the
comunidades en
participation
ese
of the
proceso de
communities
generar
in
intervenciones. Y es por eso que digo que
in
sí,
the
pero
development of
no
interventions. And
sería
that's why I'm saying yes,
suficiente o
but I think it's
correcto
not enough
interpretar
or
las
correct
herramientas
to
como una solución
interpret the
mágica.
tools as the
Parece que esa
magical solution
apropiación
of
por
silver
parte
bullet.
de
I
la
think the
acción colectiva
ownership
responsable
by the
de
collective
esta
that is
agenda de
responsible
transformación
of the
son los elementos
transformation agenda
fundamentales,
is the
así por lo menos lo
fundamental
vemos de
element.
nuestra
At least
organización.
this is what we see
Gracias.
in the organization. Thank you.
Excelente, Ernesto. Muchísimas gracias.
Excellent,
Y,
Ernesto. Thank you
bueno,
very
se nos
much.
agotó
And
el
well,
tiempo para
we
la
ran out of time
sesión de preguntas y
for the
respuestas.
Q&A session.
En nombre de
In
los que
the
están
name
organizando el
of
webinar,
those
agradecer a los 5
organizing the webinar, I'd
panelistas
like to thank the 5
que nos han
panelists
acompañado en el día de
that
hoy,
joined us
también a quienes
today,
participan,
and those
727
participating,
personas
the
conectadas por lo menos en el
727
Zoom.
people connected
Muchas
in
gracias por
Zoom.
todo el intercambio
We'd
en
like
el
to thank
chat.
you for the
Recordarles
exchanges, for
también
all
que
the
las conclusiones
sharing in
y
the
los
chat. We'd like to
materiales ya hacen
remind you
parte de
that the
este webinar, van a
conclusions
ser
and the
colgados
materials of
en
this
la
webinar
página
will be
web
posted in
esta serie de seminarios
the
que va a ser
webpage of
puesta en
the
el
series
chat
of
en
seminars,
breve.
and we will place that
Me
in
despido en
the
este momento
chat
y
very
paso
soon.
la palabra al doctor
And I
James
say
Fitzgerald,
goodbye now,
director del
and we go with
Departamento de
James
Sistemas y
Fitzgerald,
Servicios de
Director
Salud,
of
para
Systems
hablar
and
de los
Health
cierres.
Services, so
James,
that he can
adelante,
give
por
us
favor.
some
Thanks
closing
so
words.
much,
James, go ahead.
Natalia. Congratulations to you for excellent moderation of this event. My thanks to Shams, to Catherine, to Sergio, Patricio, and Ernesto, and to all the more than 760 participants actually in this webinar, engaged and really sharing your reflections through the chat. A couple of final considerations, I think, Natalia, that I think it's worth mentioning. Really, I think the work that we've seen coming from WHO Special Program and the primer forms the basis really for the application of this macro process for strengthening health systems based on primary healthcare at the country level, both at the national, subnational, and local level. And we've seen from many of the participants here really the excellent and profound experiences that exist within the regions from the various different states, countries, and municipalities. A couple of particular issues that I think that we've heard that merits really placing on the table before we finish today. Catherine really highlighted the critical issue of the challenge of funding and financing and linking that with the health workforce as a priority. If we don't have the health workforce where we need the health workforce, our vision of health systems based on primary health care is not going to become sustainable. It's not going to become a reality. So we really need to hone in and focus on that. Sergio also mentioned the issue of sustainability around the issues of integration of services and networks and the importance of really changing the model of care so that it's comprehensive based on prevention, promotion, but also obviously diagnosis, treatment, palliation. Many countries are really engaged in transformation and management and financing of health systems, but really what we need to be looking at as we implement and expand primary health care, leveraging the innovations that we've seen in COVID-19, is to see how that model needs to adapt, how it needs to be implemented, including team-based care that Sergio mentioned, and considering the inclusion of community health workers as part of that health team. So an integrated vision around primary health care as a strategic approach, really honing in on the conditions of the population, where they live, and addressing health needs. My sincerest gratitude for Patricia's participating and representing the movement of healthy municipalities and cities and communities in the Americas. I think what we heard from Patricia is the importance of a social contract for primary health care, where we are working collectively with the beneficiaries of any systems and processes that we put in place at the community level, so that we have a full understanding of the conditions of the population, of their needs, based on clear evaluation and analysis jointly with them of their health and their conditions. This is the only way forward, really, to design a health system based on primary health care. And the experience of Renka, of the Renka commune, is really a fantastic example of such an integrated approach, a people and community-centered approach, with the political commitment around the organization of health systems to address those needs. And as Ernesto pointed out, we really need to focus on issues around leadership and governance for the transformation, focusing across networks, using this word of integration as a driver, integration across the networks, across programs, and across the life course. And of course, integration in our approaches to strengthen the essential public health functions as a key element of the PHC strategy. It's so important, the issue of governance and leadership and stewardship. If we don't have that leadership and a clear vision around the governance of a system, we're not going to make this a reality. And so it speaks to the very backbone of this conversation, the need to continue advocating for the involvement and active engagement of our decision makers at all levels of the system in strengthening primary healthcare based health systems. And so it's clear from your participation here today, from all our speakers, that really primary healthcare is the driving force between effective and resilient health systems. It's the way forward to really improve health security and to ensure universal access to health and universal health coverage. And if we really want to reclaim important gains that we have lost during the pandemic, including in maternal, especially in maternal health, but also in vaccination coverage. And if we want to accelerate the elimination of communicable diseases and expand access to NCD control and prevention, this is the only approach that we can implement. And primary health care is really essential just for healthier living of all people around the Americas. So please continue to advocate and continue to engage with us around this, to work at the local level, at the subnational and national level, to ensure that primary healthcare remains a fundamental pillar and central to our efforts to ensure health equity in this region. Thank you once again, really, for everyone joining us. Thank you, Natalia. Thank you to all. We look forward to seeing you at our next webinar on August 7th. Thank you. Bye-bye.
Goodbye, everyone. Hasta luego, todos. Muchas gracias.
Gracias. Thank you very much.
Muchas gracias.
Gracias. Hasta luego.
Gracias.